discuss the case, Doctor.
Yes,
Yeah.
sir.
Yeah. Good evening and welcome you all for this evening virtual postgraduate training program of API-ICP, Tamil Nadu chapter. We have with us the faculties from the Department of Endocrinology, consultant endocrinologist Dr. Tyagarajan and Dr. Sendil. I think it means expecting Dr. Sendil to join soon, but we have with us Dr. Tyagarajan. Really thank you, Dr. Tyagarajan, for joining us, being the faculty for this evening. And we have with us Dr. Shweta is going to present the postgrad from Department of Medicine, approach to endocrine disorders. Over to Dr. Shweta and Dr. Tyagarajan to take over for the proceedings of the sessions. Thank you.
Thank you, sir.
Thank you, sir.
And Dr. Shweta, you can start with the
Yes.
case presentation, and
Yes, sir.
maybe pause every couple of a few slides. Maybe with each pass where you have a differential diagnosis, and how do you arrive at the diagnosis,
Okay,
and
sir.
we'll go forward that way.
Yes, sir. Thank you, sir. Good evening, sir. Today I'm going to present a case on endocrine disorder. A 57-year-old female, homemaker by occupation from OT, presented with the chief complaints of puffiness of face for the past 6 months. History of presenting illness. This patient was apparently normal before 6 months, after which she noticed facial puffiness, which was uniform and progressive, which was gradual onset and painless. No history of limb swelling, decreased urine output, frothy urine, fever, nasal congestion or a running nose. No history of breathlessness, orthopnea PND. No history of trauma. No history of any native medication intake. No history of neck swelling. No history of allergy to foods, drugs. No history of abdominal pain, distension or jaundice. No history of headache. No history of weight gain or loss, or no history of loss of appetite. No history of low or depressed mood. No history of joint pain or back pain. No history of gum bleeding, easy bruising or epistaxis. No history of cold intolerance, constipation.
Dr. Shweta,
Yes,
be
sir.
on the floor. Yeah. And Dr. Tyagarajan, shall I ask some few
Oh,
questions
yes, sir.
to
Please go ahead, sir.
Yeah, Dr. Shweta, you should understand it is a presentation for medicine department. So in the sense, even though case is very much directed towards endocrinological problem, the idea should be from the faculty's point of view, how you're going to approach from the internal medicine postgraduates perspectives.
Okay.
Don't try to present everything towards the endocrinological problem. It is not very much focused on that. The focused part of discussion will be done by Dr. Tyagarajan definitely. But I'm just here to guide you about how you're going to approach this patient. At the first slide which you mentioned, some
Yes.
points, interesting points for me to ask you. You mentioned painless swelling.
Yes, sir.
So, what do you mean by exactly the painless swelling only over the face? The subsequent slides you mentioned about no edema legs, certain symptoms related to cardiac also you asked about.
Yes, sir.
Suppose the patient is having a renal disorder. You mentioned about no frothy urine and no reduced urine output. But suppose this patient is having renal origin, what
Yes.
extra history would be very much useful to know about the patient might be swelling of the face could be because of renal origin.
So periorbital swelling.
Other than that, anything else? Suppose urine output is concerned, anything specific will guide you about that might be dealing with the renal tract.
Hematuria, sir. And
Why
acute
hematuria producing conditions producing facial puffiness, doctor? Dr. Tyagarajan, you don't mind to spend some
Oh,
couple of
please, sir.
minutes
Please
on
go ahead,
this
sir. Yeah, please go ahead.
non-endocrinological problem? Sorry.
Definitely, sir. Yeah.
Yeah. Which hematuria producing condition producing facial puffiness, Dr. Shweta?
Sir, glomerulonephritis.
Yes, correct. Usually starts with the hematuria, followed by subsequent in a couple of days, they might develop facial puffiness also.
Yes, sir.
But my question was two things. One is about the painful swelling which you mentioned for which is lasting for 6 months. Really
sir.
interesting point to note down because you specifically mentioned gradual onset, painless swelling. So I was not sure about the point which you are keeping in mind to mention specifically about painless or painful swelling. That's why first question was about the painful swelling. Number two question was the related to renal tract. What are the urinary symptoms will be helpful to guide you that you are dealing with a patient with facial puffiness to suspect urine output is concerned to suspect renal tract. You said urinary reduced urine output, you said first point. Then
Yes,
you
sir.
said the hematuria, then
Yes.
frothy urine you mentioned about. All these points might be giving
Nephrotic
some sort of
syndrome.
no clue that it might be, but anything else. Suppose this patient is having nocturia alone. Did you mention about nocturia?
No, sir.
No. So my question is about suppose this patient is having nocturia. What is the meaning of that symptom related to the facial puffiness of your current patient? Do you have any idea?
Uh,
Renal
yes, sir.
disorder patients, especially chronic renal disorder patient, can have nocturia as one of the important symptom. Do you know why? And what is the pathophysiology behind that nocturia happening in a chronic renal disorders? So definitely
Yes,
chronic
sir.
renal injury
Yes,
patients
sir.
can have nocturia. Go and read about the mechanism behind why the nocturia. So it is
Okay, sir.
not about the urinary output. It is not about the change in the nature of the urine content, but also you should talk about the nocturia also. It may be one of the early symptom of renal disorder where the
Okay, sir.
patient come to you with facial puffiness as a additional manifestation. Usually don't develop the painful swelling unless its inflammation is happening.
Yes, sir.
And you mentioned about gradually progressing and this one, what do you call, 6 months duration of not subsiding, continuously persisting.
Yes,
So
sir.
it's a bit of medical point of view. The conditions really to be looked into may not be that much striking features, striking conditions. Okay,
Okay, sir.
so it may be thickening of the skin can be there. Since you mentioned about no features of the what do you call the myxedema or the features of hypothyroid, as you mentioned in the last slide,
Yes,
mentioned
sir.
about constipation, cold intolerance, all those stuff. So
Okay, sir.
if it's not there, that could be specific conditions related to facial skin alone or other parts of the skin alone. Canvas clear edema can be there as a hereditary, or it may be because of some sort of conditions producing scleroderma conditions can produce. It may be a manifestation, I don't know. From the endocrine point of view, sometimes can get changes due to the growth hormone, excessive secretions also can
Okay,
produce
sir.
because I don't know anything about this case
Yes, sir.
since it's thinking about possibilities. But
Okay, sir.
endocrine point of view is different, which will be taken care by the Dr. Tyagarajan. From the non-endocrine point of view, when you're going to describe, you should know the basic points at the same time, early points and late points of presentation of any renal disorder, cardiac symptoms,
Yes,
as well as the liver related or hepatobiliary system related symptoms can produce facial puffiness. But usually the hepatobiliary and cardiac always starts with dependent edema or could be because of the symptom related to peritoneal collections, which will be more pointing towards cardiac or hepatobiliary. Whereas the renal disorders always starts with facial puffiness, more specifically periorbital. But the nocturia is one of the important early symptom of your chronic renal injury.
yes,
Other
sir.
than that, remaining symptoms, whatever described, could be possibilities of cardiac or renal, or it could be hepatic disorder producing the edema phase.
Yes, sir.
Okay.
Yes,
And
sir.
you also mentioned about so many things about the drug intake and other symptoms related to no with the no history.
Yes,
Can
sir.
you please once again go back to tell about that nasal congestion? You mentioned about hematemesis, orthopnea, all those stuff is in favor of what, doctor? Why do you want to mention about drug history? Also mention about no history of drug intake. Why do you want to mention about all those points in this patient, doctor?
Sir, any exogenous steroid consumption? Like in,
Exogenous steroid consumption. Okay. Okay, then anything else? Suppose patient is consuming on a daily basis NSAID, non-steroidal anti-inflammatory drug.
yes, sir.
She's what's her age? 30 plus or 40 plus?
57, sir.
57. So
Yes.
57, suppose having knee pain or having some sort of painkiller intake. Can this produce facial edema, doctor? Or facial puffiness? We cannot say edema, it's facial puffiness. What
Yes,
are the
sir.
mechanisms or ways the NSAID can produce facial puffiness?
Due to sodium and water retention.
Okay, NSAID can produce anything else. Direct effect of NSAID through the pathways can produce sodium and water retention, can produce facial edema. Not only facial edema, but also other parts of the body also can become edematous.
Yes, sir.
Any other reasons for mechanisms for NSAID induced edema? What is analgesic nephropathy?
Sir,
What is analgesic nephropathy?
NSAID induced tubular damage.
Is it tubular, glomerular, tubular?
Tubular interstitial.
Or interstitium? I didn't complete question.
Yes.
Or interstitium.
Yes.
Usually it's a interstitial nephritis. Tubular damage also can happen, not the glomerular damage to my knowledge, but definitely tubular. It's more of interstitial nephritis, which can produce tubular damage also, which can result in the facial puffiness can produce. Any other mechanisms of NSAID? It's a chronic injury. Sometimes you can get acute injury also. Okay.
Okay, sir.
And NSAID can produce anaphylactic reactions.
Yes, sir.
So it can produce anaphylactic
Yes, sir.
reactions, but it don't be lasting for 6 months.
It will be, yes, sir, acute.
It's acute reactions most of the time, and patients warrants immediate attention, without which patient cannot survive. It's only for it's not going to last for 6 months duration. Okay.
Okay, sir.
Yeah. So when you're going to present, just bit have an idea about the because this case, even though endocrinological problem, you try to have an idea about non-endocrinological problem related differentials also.
Okay, sir.
Okay.
Yes, sir.
And why do you mention about purpura and other things? I remember you were talking about some hematological symptoms also. Why do you want to talk about that, doctor, in this patient?
Sir, related to Cushing, sir. Easy bruising.
Mentioned purpura, I remember, right?
No, sir.
Bruising, I remember, but is it purpura did you mention about? No.
No, sir. No, sir.
Okay then.
Yes, sir.
Okay. Over to Tyagarajan, please.
Yes. So I think we can move forward. I think we went over a few things, and I think for the endocrine perspective, you talked about features of hypothyroidism as a possible differential. I think that's what you're mentioning about this constipation and cold intolerance.
Yes,
And
sir.
as Dr. Saran said, also mentioned about the possibility of acromegaly. I mean, we don't have much of symptoms that you have mentioned over there, except for the facial puffiness, which is not a typical symptom of acromegaly, but there are other things that you could ask about acromegaly symptoms. Can you name a few?
Sir.
For possible acromegaly.
Acromegaly. Sir.
Symptoms of acromegaly. Sir is asking about symptoms of acromegaly.
Sir,
You can ask about headache.
Yes, sir.
TMJ pain.
Yes.
Okay, hand and feet swelling.
Swelling. Yes, sir.
Okay, and then say typical things like either the finger rings or the toe rings getting tighter. Okay, the shoe size, the chapel size changing, those kind of things.
Yes.
Okay, all right, and then you mentioned no weight gain actually, right?
Yes, sir. No weight gain.
Oh, okay, all right, and that can go with all three of the things that we are talking about from the endocrine perspective: the hypothyroidism, the Cushing's, as well as for the acromegaly, because there will be a progressive weight gain, which you did not mention.
Yes.
Okay, and then about this duration of symptoms of being 6 months, right?
Yes, sir. Yes.
Okay. How else would you, quantify this in terms of, how this has been going on, how long this has been going on?
Sorry, sir.
Like, the facial puffiness you mentioned that's been going on for 6 months, right?
Yes, sir.
Okay. So again, when you're looking at the duration of symptoms, especially with the endocrine things such as, especially with acromegaly and Cushing's, the one thing you can look at is that ask the patient to show a photograph of picture of themselves, like say a few months ago, or a year ago,
Yes,
or a 2 year ago.
yes, sir.
Usually, nowadays most of them have them in their cell phone, so you can easily compare it.
Yes, sir.
Okay, all right. So you can proceed.
Yes. Past history, patient is a known case of diabetes mellitus. Since past 2 years, patient was on glimepiride 2 mg plus metformin 500 mg BD, vildagliptin 50 mg BD. Known case of systemic hypertension for the past 1 month on amlodipine and azilsartan. And known case of hypothyroidism diagnosed for the past 1 year. Started on low dose thyroxine, which was stopped since past 1 month. History of sterilization done 35 years back. Personal history consumes mixed
Doctor,
diet.
one second. The
Yes, sir.
drug history is concerned. Already we discussed about NSAIDs.
Yes,
With the
sir.
current past medical problems, any other drugs can produce facial puffiness, doctor.
Sir, calcium channel blockers.
What should that produce facial puffiness, doctor? Reason or mechanism behind facial puffiness in case of calcium channel blocker? Is it dihydropyridine or non-dihydropyridine? That is amlodipine-like medications or
Yes.
verapamil, diltiazem-like medications?
Use.
Usually,
No.
calcium blockers can produce usually gingival hyperplasia.
Yes, sir.
Sometimes this type of minimal urticarial or minimal anaphylactic like lesions can be there,
Yes, sir.
acceptable. Any other drugs can produce facial puffiness. I'm talking about other than the leg edema, you can get
Okay, sir.
facial puffiness also minimally. But any other drug can produce edema face with diabetic medications.
Diazolidine.
Yeah, so glitazones can produce.
Yes,
Anything else can produce weight gain and minimal facial swelling like appearance. Suppose
instance.
patient is going to be on secretagogues, especially sulfonylurea, along with insulin therapy, or per se sulfonylurea can produce facial swelling or as it is as a weight gain. It may
Okay.
not be like edema, but
Yes.
weight gain is one of the known factor to happen with secretagogues or
Yes.
secretagogues plus your insulin therapy.
Okay, sir.
Dr. Tyagarajan, anything else you want to add regarding this drug-induced facial swelling or weight gain, Dr. Tyagarajan?
Yes, I think mentioned sulfonylurea and insulin. Yeah, so insulin therapy definitely will can cause the maybe mild edema and weight gain particularly. It
Yes.
increases the vascular flow, so you can the vascular dilatation happens. So there may be some edema with that. Other than that, I think the calcium channel blockers we already discussed.
Yes.
And
Glitazone,
glitazone.
yes, the glitazones
Yes,
we
sir.
talked about, yes. And acute reactions, ACE inhibitors can sometimes cause angioedema type
Yes.
reactions, but again, those are acute situations, not like long for 6 months.
Yes.
And hypothyroidism mentioned, you mentioned about low dose. So I'll also explain sometimes if it's uncontrolled. That means
Yes.
poorly titrated and it is not, it's a, what I call that, not under good control. You can get this type of facial puffiness also. Even though the very clear points are mentioned by you, the constipation or other
Yes.
weight gain is not there, cold intolerance is there. In drugs is
Yes.
concerned, we can think about these possibilities also. Okay.
Yes.
Because
Yes.
the idea is to just think about and try to rule out is the way of moving forward with the historical aspect. Okay.
Okay, sir.
Yeah, go ahead.
Personal history. Patient consumes mixed diet, normal appetite, sleep normal, bowel and bladder habits no alteration, and patient is in normal mood. Family history, upper middle class family, born out of non-consanguineous marriage, no significant family history. And menstrual history, patient attained menarche at 13 years old. The cycles were regular with normal flow. Obstetric score is P3L2, normal vaginal delivery. Attained menopause at 45 years of age. Summary. A 57-year-old female who noticed gradual onset of facial puffiness about 6 months ago, involving the entire face progressive, giving a rounded appearance. There is no pedal edema or abdominal distensions. My differentials are nephrotic syndrome. There is no history of frothy urine, anasarca symptoms. So the nephrotic syndrome is ruled out, and there is no history of infection hematuria. So acute glomerulonephritis is ruled out. Yeah, for mixed edema, no history of cold intolerance, weight gain. And for in superior mediastinal syndrome, there is no history of any breathlessness and swelling. Ec- uh, any facial congestion with postural variation of swelling. And for congestive cardiac failure, there is no other exertional breathlessness, no pedal edema. For severe hypoproteinemia, there's no other histories like I say abdominal swelling or uh, pedal edema. So the symptoms favor Cushing syndrome.
And doctor, in your patient, the acute glomerulonephritis, why do you bring in as a differentials, doctor? You're saying 6 months history gradually
Yes.
progressing.
Yes.
How will you bring in acute glomerulonephritis as a symptom? Sorry, differential, doctor. So you cannot bring in any
Yes.
acute condition as differentials in your patient at all.
Okay, sir.
Suppose if you're saying that 6 months back, one episode, 1 week duration recovered, once again, this time could be an acute episode of chronic or it could be an acute disease as it is. But
Yes.
what you said is 6 months gradually progressing. So you cannot bring in any acute disease as in
Okay.
differentials in your differentials at all. Number one. Number two, you said frothy is the only symptom in favor of nephrotic is not to be considered as a significant symptom.
Okay,
So
sir.
frothy can be there. It may not be significant, saying that it is not signifying that you're dealing with a proteinuria. So it
Okay.
is usually as a symptom of proteinuria. Suppose even non-proteinuric conditions also can produce frothy urine. So in that case, that's not the only way to look at. Okay.
Yes, sir.
Yeah. And why do you say Cushing's in this patient, doctor?
Sir.
You said there is no other symptoms, drug history, weight gain, nothing is there, 6 months duration. Why do you think about Cushing's in your patient? And you said no ecchymosis, no easy bruisability, so many things you mentioned about, right?
Yes, sir.
Then why
Sir,
do you bring in Cushing's here?
the uniform swelling round faces.
Mm-hmm. So did he mention about anything on the over-the-counter medications, doctor?
No, sir. No history of
Over the,
no such history, sir. No use of any other medications over the counter medication.
you mentioned about that, right?
Yes, sir. I have mentioned about native medications.
Native medication. That's what. At least you had mentioned about native medications. The only point correction here, I would say that there is no need to bring any acute condition in your patient.
Okay. Okay, sir.
Whatever the differentials you want to offer, you should be having justification.
Yes.
But I don't expect you to tell only acute disease in this chronic history of 6 months duration.
Okay, sir.
Dr. Tyagarajan, anything else you want to add, you can add.
So yeah, at this point, I think like Dr. Saravanan said, the acute glomerular nephritis is like it's not an acute situation; it's a progressive disease, as you said. And at this point, with just the history, I think the differential can just leave it broad as it at this point, and don't eliminate any of these at this point. I would say.
Okay, sir.
Okay, you can go ahead and proceed.
Okay. Gen- General examination, the patient is conscious, oriented, and afebrile. No tachypnea, not dyspneic. No pallor, ictus, cyanosis, clubbing, lid for the patentima. Patient is moderately built and nourished. Patient has central obesity, round faces, dorsal fat pad plus, supraclavicular fullness plus, venous hypertrichosis present, abnormal fat deposits present in bilateral forearms, hyperpigmented patch present over bilateral legs, and purple striae noted over the lower abdomen. And vitals and anthropometry.
Was there any dependent edema over the face, doctor? You're mentioning about repeatedly mentioning about round faces.
Yes, sir.
I am more interested to know about is there any dipping on pressure or not?
No, sir. Non-pitting.
You have to mention about that also. Now,
Okay, sir.
whatever the things you are saying
Yes,
could
sir.
be associated with the fluid also.
Okay, sir.
To say it's an extracellular fluid compartment, it is plain water-like material because of hydrostatic pressure, increased nature, or hypoproteinemia, reduced oncotic pressure. You'll be having this type of the round faces also because of fluid collection.
Okay,
So you
sir.
need just to tell about, because you're talking about general examination, which includes your inspection palpation, right?
Yes, sir.
Yeah. So that means you'll be able to, or should be able to, or looking for this one. Are you able to see any venous distension over the face, doctor?
No, sir.
Because you mentioned about SVC syndrome also,
Yes,
or
sir.
thoracic outlet syndrome.
Yes,
Did you mention about in your patient's examination finding, or you didn't mention?
sir. I didn't mention, but there is no venous distension over the neck or face.
Yeah,
Just
that has to be mentioned because
yes,
what I'm trying to tell you is you have the differentials at the end of the history,
yes,
maybe
sir.
4, 5. Number
Yes,
one,
yes,
you
sir.
are saying some justification for the order of differentials. Number two,
Yes, sir.
number three, you are trying to say justification not only based on the historical aspect, you're trying to say yes or no or for or against in your differentials from the examination also.
Okay, sir.
Okay, so each and every step of your exam should be having whatever your differentials offered should be examined by you as a for or against your the differentials order.
Yes, sir.
And you said about history wise there is no bruisability, there is no ecchymosis from the historical point, but you are able to demonstrate. Did you check with the patient? Did she notice these points or she was not able to give importance for those signs?
She doesn't give any importance to the science, sir. Just
Okay. So even though the signs were there, the
yes,
patient felt it is not to be important.
yes,
So
sir.
she didn't give yes to your question, right?
Yes, sir.
Okay, please go ahead.
Yes. Vitals.
What's the next circumference, doctor?
So neck circumference.
What is Bird's index? You said repeatedly makes me to think a different way of looking at this patient's problem because you've been said round faces, bit of plumpy, all those stuff. Immediately my thought process gone into different direction. What's the tongue size? Tongue.
Normal.
Does she have any? The posterior pharyngeal wall was bit of narrow.
No,
Other
sir.
than the buccal pad, sorry, you said about the nape of the neck, some sort of fat pad is more. What about the front of the neck?
Sir, in the supraclavicular fullness is present.
Okay. And another point is, did you ask about? I forgot to ask about after this signs. Did you ask about history of snoring and daytime sleepiness?
Yes, sir. There is no such history, sir.
You mentioned about that.
No, I forget to mention, but I asked the history.
Forgot to mention. How can you forget? You're seeing a patient with the facial puffiness. You should ask about this snoring and daytime sleepiness, irresistible sleepiness,
Yes,
affecting the daily activities of living in the daytime. That should be asked about.
yes.
Irrespective of whatever the differential is going to offer, whatever the diagnosis, doesn't matter.
Okay, sir.
Okay, that should be
Yes,
asked about. Okay, this patient is prone for obstructive sleep apnea.
yes, sir.
They're prone for whatever the disease nature, they are
Okay,
prone for obstructive sleep apnea. That should be elicited for.
okay.
So you didn't answer that question of neck circumference and Bird's index. Go and read about birds index. Anybody is having facial puffiness, neck a bit swollen, you always ask for the birds. Look for the birds index.
Okay,
Okay.
sir. Okay, sir.
Yeah, please. Go ahead.
Yes. Blood pressure 130/70 mmHg measured in right upper limb in sitting position. Heart rate 96 per minute, regular, normal volume, no specific character, no radial or femoral delay. All peripheral pulses felt equally. Saturation 99% in room air. Respiratory rate 20 per minute. Abdominal thoracic type. Temperature normal and height is 160 centimeter. Weight of 67 kg. BMI 26 kg per meter square. Arm span of 160 centimeter. Waist circumference of 86 centimeter and hip circumference is 108 centimeters. CVS S1, S2 year, no murmurs. In respiratory system, bilateral normal vesicular blood sounds yet, no added sounds. Perabdomen was soft, non-tender, no organomegaly. And central nervous system examination, patient no focal neurological deficit present. Spine, no tenderness present and no deformities. In musculoskeletal, no deformities and oral cavity was no.
Now, what neurological deficit you looked for, doctor?
So, cranial nerves.
What cranial nerve? Which cranial nerve?
Sir, in pituitary cranial nerves of 3, 4, and 6.
Why?
Mm, Due to cavernous macroadenoma causing cavernous sinus compression, causing some
What symptom will we have? And sign?
diplopia.
Uniocular diplopia, binocular diplopia. Okay, any other symptoms or signs you expect from the neurological point of view in this patient? So you're not sure about, still we are thinking about some possibilities of a neurological problem. We have
Yes.
not finalized it. We are thinking about, yes, definitely, yes, you said Cushing's is one of the possibilities in the differentials. But keeping in mind that patient is obese, edematous or bloated faces, ecchymosis, bruisability, all those stuff is there. What are
Yes.
the neurological deficits can expect? We look for the proximal muscle weakness in this patient.
Yes, sir. There is no proximal muscle.
Do you expect any wasting is there or not?
Yes, sir.
Do you expect or do you not expect?
Yes, sir. Wasting. There is no wasting, sir.
But are you expecting is the question.
Yes, sir.
Why?
Proximal muscle myopathy will be present.
Myopathy usually presents with the wasting or only muscle weakness, pain, and only late stages of disease, only myopathy will have wasting.
Okay.
That's my question, doctor.
Oh, sir.
So myopathies always will have the late stage of the myopathy, only will have the wasting. Most of the time, the muscle bulk is maintained, but the weakness can be there. The
Yes, sir.
power may not be that much effective compared to the size of the muscles. But when the disease progresses to a stage where you can get complete wasting happen, whereas neuropathic disorders always starts with the wasting, the weakness is proportional to that. Okay.
Okay,
It's
sir.
very important to differentiate between the neuropathic and
Yes.
do you expect any problem in the neurological system other than the muscle weakness, muscle wasting, all those stuff? And she's also nicely mentioned about the spine tenderness. Did she mention about any height size? Means height is come down from the compared to that. Did anybody said that the height part is slightly shortened compared to the previous years of her height?
No, sir.
What is
There
the
is
clinical
no
relevance?
osteoporotic fractures of spines.
Compression fractures. They can
Compression fracture.
develop a compression fractures,
Yes.
which may not be having such a neurological deficit, but they can produce some sort of height
Yes.
can go in a gradual manner. maybe an inch or maybe 1.5 inch can go down, which will be
Yes.
very much grossly visible to the newly looking at the person
Yes.
compared to the younger age group or
Yes.
younger age or the previous ages. Okay.
Okay, sir.
Yeah. Any other neurological symptoms? Can you get neuropathy of peripheral origin?
Yes, sir. Peripheral neuropathy rarely may be present.
What type of peripheral neuropathy can get? Just keep in mind, a person is
Yes.
developing gradually progressive body bloating, which
Yes.
includes your face, arms, trunk, every part of the body is bloated,
Yes.
which are the peripheral nerves can get involved to produce manifestations. Suppose this patient is saying, I'm not able, she's being a lady involved in the kitchen activities, she is saying, I'm not to do any activities of washing my vessels.
Yes,
I
sir.
am not able to do my kitchen work very frequently, which is really requiring my movement at the distal parts.
Yes, sir.
So, what neurological system related structure involvement producing the symptom? You understand the question?
Yes, sir.
Hmm. But Tyagaran, just bear with me. I'm just trying to
Oh, please
engage
go
in
ahead, sir.
non-underground. Yeah,
Yes, yes,
please.
please go ahead.
Yeah. So, what are the symptoms you can get in carpal tunnel syndrome, doctor?
Sir.
To try to
Distant.
understand any
Yes.
disease producing volume overloaded status,
Yes, sir.
also can involvement the tunnel which is through which the nose or median nerve is going can
Yes, sir.
be involved in producing disturbance of the conduction pathway, which can produce the symptoms of carpal tunnel, which can be in the form of milder version to severe form also. So
Okay, sir.
milder version, usually the extremes of wrist movement
Yes.
can produce minimal amount of pain. Sometimes can go to the extent that patient may not be maintain the power at the distal part when they're trying to do movement, which is really recovering the movement of the wrist at the extreme positions like
Okay.
flexion or extension movements. The pain not necessarily distally spreading. You can get even up to the level of elbow. Proximal also the pain can go. So forward and backward pain can happen with the carpal tunnel, which is commonly seen with any disease which is producing volume overload, which is applicable to your the Cushing's also, myxedema, or your hypothyroidism, or drug-induced problem like steroid-induced problems, or NSAID-induced, or any other volume overload states can produce, which includes your diabetes, which includes your rheumatoid arthritis also.
Okay, sir.
So these are some neurological structures can be involved person with the volume overload status or
Okay.
big bloated faces and including the other trunk part also involved. You can get these type of neurological symptoms. Okay,
Okay.
just if I guess
Yes.
what I'm expecting you is it
Yes,
is
sir.
not pointing towards what are the signs you elicited. You're
Yes, sir.
thinking about your differentials
Yes.
and try to look for the additional symptoms and signs on symptoms, signs related to the differentials.
Okay.
Okay,
Okay, sir.
because you offer some 4 5 differentials for which you have mentioned about the edema is there or not, that is fluid collection is there or not, any
Yes.
other neurological deficits, something
Yes.
like this you should be looked for. Okay,
Okay, sir.
and similar to that, you mentioned about superior vena cava syndrome, which you are supposed to mention about the veins distension, any
Yes.
positional changes, conjunctival suffusion.
Yes.
Okay,
Yes, sir.
but neurologically you said normal. I don't know you looked into the fundus of this patient or not. Did you?
Yes, sir. Fundus normal.
You mentioned about that?
Sir. No, sir.
Every examination history you're saying, yes, sir, I asked for it, I'm sir, I'm examined, but you're not mentioning about that. That means you're not examined.
Sir, I am examined.
You're talking about cavernous sinus involvement, you're talking about pituitary macroadenoma, you're talking about 3, 4, 6 cranial nerve involvement, but you didn't say about the fundus examination.
Sir,
Okay,
I
next
did.
step.
I did fundus. Fundus
It
was.
should have been mentioned by you, right? It
Yes,
should have
sir.
been because it's neurological, it's part of a neurological examination. This
Okay,
is
sir.
what I have been telling or insisting on the importance of fundus in all the patients.
Okay, sir.
Whether you are dealing with the cardiovascular, respiratory system doesn't matter. It's a routine examination, basic routine examination, which
Okay,
you are
sir.
supposed to look for.
Okay,
No
sir.
compromise on it. Over to your Tyagarajan, please.
Yes, Dr. Shweta. So, it seems like at this point, kind of, you are based on the physical appearance, you are narrowing down towards Cushing's. So, as Dr. Savana sir also already mentioned,
Yes.
other than the anabolic part of the Cushing syndrome, where the patient is gaining weight and is
Yes.
having obesity and all that, there's also a catabolic part to it. That's where you start seeing this, easy bruising or ecchymosis that you see.
Yes.
And things that you can easily see are that when the patient had a blood draw,
Yes.
where the needle has poked the vein, if you see that, they you can easily see the bluish blackish, the discoloration of the skin right there. So that's
Yes.
one thing you can look at. And then you ask the patient, just do a proper examination of the peripheries, whether the patient has recently, even small trauma to the skin can cause the bruising. That's something you can easily look for and check at that. And
Yes.
then, what we used to call, potato on a stick, in the past, now with the central obesity, but the peripheries are very thin, and, as the disease progresses, you
Yes.
also see the skin under the underlying tissues getting wasted. That's when you start the thins getting, the limbs getting thinner.
Yes.
And for proximal muscle weakness, you can easily ask them if they have difficulty combing their hair, to
Yes.
look at the shoulder girdle power. And also simple, like, squats, you can ask them to just squat in the clinic room. Now just ask them to squat and get up and see if they are having difficulty getting up from the floor. And the patients usually tell you that they are not able to get up from the floor when they sit down, or those easily that can be elicited.
Yes.
As far as the like when you are looking at possibilities of hypothyroidism, you can look for thyroid enlargement. And for acromegaly, again, the facial features that you can look at, whether there's any coarsening of the skin, and the gap between the teeth is increasing. So those
Yes.
kind of things, when the jaw, the mandible is protruding, those kind of things are still a possibility in acromegaly that you should look at.
Okay.
And macroglasia can happen in both with the thyroid, as well as with severe hypothyroidism, as well as with acromegaly. And heel pad, thickness of the heel pad you can look at, and that can also happen with the acromegaly. So these are simple things that you can just a visualization, you can see. These will give you more clues.
Okay. Okay, sir.
Now, I have a basic question to you, Dr. Shweta.
Yes, sir.
How will you palpate for thyroid gland, doctor? Very, very basic question. It may be preliminary question, but it's worth it to ask now.
I'm standing behind the patient.
Okay.
Sir, patient in sitting posture, standing behind the patient, we should palpate for the both lobes of the thyroid.
That's what the question is about. Okay, go and learn about that or revise about that.
Yes.
Second question is about, you said about she's sitting para 3, right?
Yes, sir.
She is having 3 children, right?
Yes, sir.
Live children, 3. Okay, so you said about some striae over the abdominal wall, right?
Yes. Yes, sir.
How do you differentiate this striae from the abdominal striae secondary to pregnancy related versus the Cushing's related?
The purple striae in Cushing's.
Why is purple color, doctor? The pregnancy, you mean to say white color? It is the red color or green, yellow? Which color you like?
Sir.
Pregnancy is white color or some other color?
No, sir. Pregnancy is pink, purple, then fade to silver, white colors.
I didn't get your answer clearly, doctor. So go and search for the answer, how to differentiate pregnancy related, this striae versus Cushing's related. Did you look for any striae over the gluteal region, the upper gluteal part?
No striae, sir.
She didn't have, or you didn't look for it?
Looked, sir. No striae.
Both thigh and the upper gluteal region, right?
Yes. Yes.
So go and learn about this part.
Yes, sir.
Suppose this patient is abdomen examination, she is having the liver is palpable.
Yes. Okay, sir.
How will you interpret that? He said no organomegaly, there is no free fluid, right?
Yes, sir. No free
Yeah.
flowing.
Yeah, you said no organomegaly, no fluid. Suppose this patient is having enlargement of liver. Liver span is increased. It is not palpable alone. Liver
Okay.
span is increased. How will you explain that in this patient? A person whom you are dealing with volume overloaded or bloated symptoms for 6 months duration. Now
Okay,
you
sir.
are trying to narrow down your differentials to some sort of endocrinological problem where
Okay.
you are talking about most probably you are dealing with related to the hormone imbalance of adrenal gland, whatever the reason is adrenal
Metabolic.
gland whatever is there. How do you explain that hepatomegaly in this patient? Even it's going to be
Fatty
hypothyroidism
infections.
related or it could be because of growth hormone related. If you are able to palpate the liver and it is liver span is increased, how will you explain that in this patient?
Sir, fatty liver metabolic syndrome.
Metabolic syndrome we can get because of the metabolic syndrome related enlargement of liver can happen.
Yes, sir.
Okay,
Yes.
that should be kept in mind. That is one of the possibilities. There are so many other reasons might be there, but without much of any other history, only the symptoms and signs what we are discussing, we are trying to explain the possibilities of enlargement of liver in relation to the
Yes, sir.
endocrinological problem, the way of thinking. Okay.
Okay.
Yeah. Can you get splenomegaly, doctor?
So uh, if Marshall develops portal hypertension, then it
There is
can.
another part. Another
Yes.
part. I'm talking about only if you don't know anything about the muscle is there or not.
Yes.
Ah. So mild splenomegaly tip can be palpable in case of these 2, 3 endocrinological problem. What you're talking about can be there. It may not be truly a disease of spleen as it is. Could be an enlargement of spleen happen with your 3 disorders. You're talking about growth hormone,
Yes.
thyroid hormone, as well as your adrenal gland hormonal imbalances can produce minimal amount of very tip can be palpable, or at least deep palpation can get the tip of the spleen can be palpable. Okay.
Okay, sir. Okay, sir.
Yeah. Go ahead, doctor, please.
You can easily see, some of these features in, the exogenous steroids-induced Cushing's.
Yes, sir.
Those are the patients you would see more frequently in practice.
Yes, sir.
And these are the patients who actually manifest all these skin manifestations very easily. So you can see, even in the upper arm, you might see some striae sometimes, real thinning of the skin.
Yes, sir.
They call it like the cigarette paper type of skin. So when you see the skin over their hands and the fingers, they will be
Yes.
very thin. So you can easily find that out. And
Okay,
in
sir.
difficult cases, there's actually some ways to measure it. You can use the triceps skin fold thickness. That can be measured using some skin calipers also,
Okay, sir.
and those can also be done.
Yes.
Go ahead, actually.
Yes. So the diagnosis here is Cushing syndrome. Um, the Cushing syndrome may be ACH dependent or non-ACH dependent. The ACH dependent causes are pituitary adenomas, pituitary tumors, ectopic ACTH secreting tumors. In non-ACTH, it can be the adrenal adenoma or carcinoma, and other pseudo Cushing's syndrome causes are severe depression, severe alcoholism, or obesity. On investigating, the patient is having a.
Doctor, you are dealing with the problem of only Cushing's or anything else? The diagnosis, doctor.
Sir,
Because completely misguided or what you call biased. I don't say misguided, biased towards your the class what you are discussing today. That's why the beginning onwards, I'm just telling you about be more of postgraduate of internal medicine. Don't be a only endocrinological problem. You said about patient is diabetic.
Yes, sir.
You said about patient is hypothyroidism, hypertensive,
Yes.
and she's also postmenopausal. So all those things are bit of diagnosis, right?
Yes.
Postmenopausal also normal physiological endocrinological situation.
Yes.
Right. So there's so many points are there as a diagnosis. You said about only Cushing syndrome. And what is there any possibility of getting what is disease and what is syndrome, doctor?
Sir.
Both are same.
No, sir. The ACH dependent pituitary cause is called a Cushing's disease, sir.
Hmm.
Uh, the Cushing syndrome is a broad term for all causes of cortisol excess.
Okay. So disease pointing towards only pituitary
Pituitary,
adenoma or pituitary disease. It can be anything.
sir, pituitary adenoma causing
You're
ACH
not prepared. You're not prepared, doctor, for this class.
prepared.
Prepared with more nervousness,
Yes.
right? Because each and every time you're trying to give more clues, but you're not coming out with the answer. Sounds to me for me more of nervousness. Don't be nervous. It's a platform for you to explore your possibilities of whatever mistake you want to commit, you can commit here. There is no problem at all. Exam, you cannot have the pleasure of making mistakes. You're supposed to answer to the questions correctly.
Okay, sir.
Otherwise, marks are marked there. Here, there is no marks. You
Yes.
try to make a mistake. Don't be nervous.
Yes.
Bit clear and try to present whatever and learn more and more.
Okay, sir.
Otherwise, you don't get a platform of this nature to present your cases, right?
Okay, sir.
Yes, please go ahead.
And actually, I think you're not arrived at the diagnosis yet.
Yes, sir.
So you still have Cushing's as your differential, is what I would say.
Yes, sir.
Okay, all right, go ahead.
On investigating, CBC showed mild leukocytosis and uric rate was normal. Sodium renal parameters were normal, and bicarb there is mild alkalosis was present. And on the random cortisol was elevated. And
Before that, doctor, the sodium, potassium, anything specifically you want to highlight
yes,
in your patient,
yes, sir.
whatever the diagnosis you're offering,
Yes, sir.
all the differentials along with the primary diagnosis of diabetes, hypertension, hypothyroidism,
Yes, sir.
how much importance you want to give the weightage for stressing upon the point on sodium, potassium?
Sir, there will be hypernatremia and hypokalemia with alkalosis in
In case of
AC, uh, ACH, ACTH dependent
why?
due
Suppose
to mineral.
primary adrenal gland involvement
Yes, sir.
producing, it's a pituitary gland induced problem. How will you differentiate basic points? Okay, probably Dr. Tyagarajan will discuss further. We'll just go ahead with the presentation after the tolerance involved.
Yes.
Go ahead, go ahead.
A, the ACTH was elevated 196, and overnight DEXA suppressant test, the cortisol was 27, which is also elevated, and MRA was done, which showed large heterogeneously enhancing cellular and supracellular lesions of 1 into 2 to 3.2 centimeter with multiple cystic areas causing elevation and compression of optic chiasma, scalloping and bulging into sphenoid sinus, and possible cavernous sinus invasion likely to represent pituitary macroadenoma. So, image of pituitary macroadenoma extending into the sphenoid sinus, and the uh, diagnosis is ACTH dependent pituitary macroadenoma causing Cushing's disease, and patient underwent transnasal transeptal transprenodal hypophysectomy, and the biopsy showed the pituitary neuroendocrine tumor with low Ki-47 proliferative index.
Dr. Tyagarajan?
Yes, sir.
Yeah, I think you can start the discussion from the endocrinological point of view, Dr. Tyagarajan.
So yes, Dr. Shweta. So I think you mentioned about the random cortisol level, right?
Yes, sir.
Okay, so now what do you need to make a diagnosis of endogenous hypercortisolism? What test do you do to?
Sir, we can do 20 early 8 a.m. cortisols. 8 a.m. cortisol, serum cortisol, uh, um, 24-hour urinary free cortisol levels can be checked, sir. And midnight salivary cortisol levels can be checked.
Okay, but you did mention about the overnight dexamethasone suppression test, right?
Yes, sir, I mentioned this.
Okay,
Yes.
so yes, so to diagnose endogenous hypercortisolism, excess cortisol being produced, a random cortisol level is not very useful.
Yes, sir.
Okay, so
Yes.
before that, in this particular case, your differential, the top differential is Cushing's.
Yes, sir.
So we can call this as that you have a high pre-test probability for Cushing's syndrome in this patient, right?
Yes, sir.
Okay, so in that case, yes. So a random cortisol, even a morning cortisol, you cannot make a diagnosis of Cushing's syndrome. So
Okay,
in
sir.
this situation, so the three things you mentioned, like one is the 24-hour urine-free cortisol.
Yes, sir.
Okay, and
Yes.
how does that give you the diagnosis? What's the physiological or pathophysiological basis behind measuring a 24-hour urine-free cortisol?
The more than
So actually, you can think of this as three ways. Okay, when there is endogenously excess cortisol being produced,
yes, sir.
so we are looking at three things. One is this midnight salivary cortisol you mentioned, right?
Yes, sir.
Why is that important? How is that? What's the basis
Midnight,
for?
the cortisol levels will be low in the night, and it will be high in the early mornings.
Exactly, yeah.
Yes.
So the cortisol levels follow the entire hypothalamus pituitary adrenal axis follow a circadian rhythm. So at
Yes.
midnight, you expect the cortisol levels to be lower.
Yes.
But now, in terms of an adrenal tumor or a pituitary tumor or any ectopic ACTH secretion, these cortisol levels do not follow the circadian rhythm. So that's why this midnight salivary cortisol is higher. How
Yes.
about this 1 milligram dexamethasone suppression test? What's the basis behind that?
Sir, when we give 1 mg Dexa at 11 p.m. of night, and we measure cortisol at the early morning, there should be a suppression of cortisol in the morning, sir, due to.
Yes, you're right.
Sir,
Okay. So
yes,
yeah, the exogenous steroid should
yes,
suppress the entire axis, the
yes,
hypothalamus pituitary adrenal axis.
yes, yes,
So in any terms of it, like again in an adrenal tumor or a pituitary tumor, this suppression is not maintained.
yes, sir.
So you still have higher cortisol values even after a 1 milligram or any dexamethasone given within the
Yes,
previous diet or the previous 2 days.
yes,
Okay, what's that again? The 24-hour urine-free cortisol.
sir. We should measure the total free cortisol exerted for the period of 24 hours, and it more than 400 microgram per day is suggestive of hypercortisolism.
Sure. Okay. So I think, whatever the excess cortisol being produced
Yes, sir.
is not, bound to the saturated. It is saturated. The cortisol binding globulin is saturated.
Yes,
So
sir.
the rest of the excess free cortisol is filtered through the kidneys and you get it in the urine. So if you measure it over a 24-hour period and if it is high, then you
Yes,
make the diagnosis of Cushing syndrome.
yes,
And Dr. Shweta,
yes,
you are
sir.
checking in the fasting cortisol level
Yes, sir.
and you are using also the corticosteroid.
Yes, sir.
How is it going to go, doctor? You're saying you're using the dexamethasone suppressant test.
Yes, sir.
Will that interfere? You are also using the exogenous, it's also steroid preparation, right?
Yes, sir.
Will that interfere with the assay? Why you are not using overnight prednisolone test? Why you are not using overnight methyl prednisolone test or hydrocortisone test? Why are you using only dexamethasone test, doctor? Whatever I said is 4 preparations. I said
Yes,
all
yes.
are steroid
Texas
preparations. All are
long
steroid,
duration.
right?
Yes, sir.
All are steroid. Why
Yes,
you
sir.
are using only dexamethasone? Will it interfere with the cortisol assay? Is the question.
So this is long acting.
So what? So long acting won't be there in the blood. Huh?
No,
Before reaches its peak value, will take the blood. Huh?
no, sir.
Hmm. Did you think about this? You are using
Yes,
analysis of the cortisol value
yes,
or the blood, the whatever the gland related effects, but you are using the same corticosteroid or steroid preparations. How does it go? Just think
yes,
about
sir. Yes,
and go and find out the answer.
okay, sir.
Okay, it's a valid question, but you should think
Yes,
about and go and find out the answer. Tell me tomorrow.
okay.
Okay.
Yes, sir.
And do you go for 24 hours or 48 hours dexamethasone suppressant test?
Sir, overnight extra suppression test alone done, sir.
No. My question is about not what was done to this patient. I'm asking about what other things can be done for a
Yes,
person who is having this type of suspected
yes,
the endogenous corticosteroid production excessive.
yes, sir. 48 hours dexa methasone test can be done, sir.
What is it? What
Uh,
dosage do you use?
sir, a total of 2 mg, sir. 0.5 mg uh,
Every?
every 12 hours.
I think you're not prepared well, doctor. Sorry. Just shown some interest and prepared well, doctor. 48 hours test, low
Sir,
dose
every 6
dexamethasone,
hours.
high dose dexamethasone.
Sir, 0.5
Okay,
mg every
go
6
and
hours for
prepare.
48 hours, sir.
Mm. Where do you use 2 milligram per every 6 hours for 48 hours?
That is a high dose dexamethasone test. This is low.
Mm-hmm.
For low
What is the
dose, we use
proper?
0.5.
So Dr. Shweta, Dr. Saran is asking, when do you do the high dose dex suppression test?
So many tests
So
are there for
differentiating
any
is
disease. There's a meaning for it, right? Mm.
is for differentiating ectopic versus pituitary ACT.
Mm. Okay. But Tyagarajan, please.
Yes, so Dr. Shweta, so I think at this point, you have come to the diagnosis of Cushing syndrome. Now, how did you make it to the doing the MRI scan? Like, how did you move to the next step of doing the MRI scan?
Sir, this is ACTH dependent. ACTH was done, which was elevator, sir. So,
Okay.
So hence, to rule out pituitary causes, MRI was planned.
Is there any possibility of ectopic ACTH, Dr. Shweta?
Sir, but there is no other features.
What other features? Or otherwise, how will you say it's the specific pituitary origin of ACTH dependent, this elevated values versus ectopic ACTH production?
Sir, the ACTH levels will be very high in ectopic ACTH, sir. More than 300 nanogram.
So only the values will tell you. Any
And
other features?
other ectopic ACTH causes of will be small cell lung cancers or other carcinomas. There is no other features suggesting of carcinoma.
Sometimes may not be there, right? The primary disease related, wherever the ectopic ACTH is originating from, may not be having symptoms. The
Yes, sir.
meaning here is you are trying to look at the endocrinological problem. You are trying to evaluate the level at which you have the problem in the axis, producing this hypercortisolism. You are come to a conclusion that you are dealing with an ectopic based on whatever the parameters, clinical and laboratory parameters. It is very important not necessarily to have a symptoms related to the primary origin of ACTH other than the pituitary. We are supposed to screen for it also.
Okay.
Symptoms not necessarily always may be there. If
Yes.
it's there, well and good, you're going to focus on the primary site of ectopic ACTH production site.
Yes.
If it's not there also, you're supposed to screen for it. Okay.
Okay.
Yeah.
Dr. Shweta, I think this case, the historically also the clues are there. If it is an adrenal Cushing's or if it is an ectopic Cushing's, the
Yes.
progression of the disease would be much faster and much severe.
Yes.
So even Dr. Sardan was mentioning about the potassium values, the hypokalemia. So the
Yes.
hypokalemia will be much more pronounced in an adrenal origin Cushing's and
Yes.
also in an ectopic ACTH because these are, especially the ectopic ACTH are very progressive diseases, very fast progressive diseases.
Yes, sir.
So you will get very clues such as this, very increased weight gain, the facial features changing, diabetes getting on, hypertension getting out of control very fast.
Yes.
Okay, and in this particular moment, this is postmenopausal, but otherwise, in a premenopausal woman, you will start seeing menstrual irregularities. And you did mention about villus hypertrichosis, and those things would be more prominent.
Yes.
Yeah, but I think you're right in mentioning that the ACTH levels are not high enough to suspect. But those things should not be taken as the sole criteria to rule out an ectopic ACTH.
Okay. Okay, sir.
Okay, in this particular case, would you have repeated or done any of the other tests that you mentioned other than the dexamethasone suppression test?
ACTH done, sir. No, no, sir.
Okay, so I think in this particular case, from your history wise, your the Cushing seems to be in the top of the differential. So your
Yes.
pretest probability was high. So one particular test, this 1 milligram overnight dexamethasone test was positive,
Yes.
and so that gave you the diagnosis. But in most cases, it's better to confirm with two tests.
Okay.
So if one test is positive, then maybe confirming it with another, either a 24-hour urine cortisol or
Yes.
a midnight salivary cortisol may be needed. Most of the time you need two tests to confirm the diagnosis.
Okay, sir.
And as for the 1 milligram dexamethasone test, do you know the cutoff values?
Yes, sir. More than 5 microgram per deciliter suggestive of hypercortisol.
Okay. And when do you rule out?
Sir, less than 1.48.
Okay, so 1.8, less than 1.8 microgram per deciliter. Okay.
Okay, okay, sir.
So, in other cases, this case is different. But in other cases,
Yes.
when you're trying to rule out Cushing's,
Yes.
okay, so you have the cutoff as 1.8, and if it's less than 1.8, then you can rule out exogenous Cushing's.
Okay, sir.
Especially when the pretest probability is on the low to medium side.
Okay, sir.
Like, say, for example, an adrenal incidentalloma.
Yes.
Okay, so you have a higher sensitivity when you keep the lower cutoff of 1.8.
Okay, sir.
But you're right, the specificity goes up when the cutoff is kept at 5 microgram per deciliter. When the levels are more than 5, then the possibility of a Cushing's is more likely because the specificity is higher at 5 microgram per deciliter.
Okay, sir.
Can you say in maybe any condition where you may get a false positive or a false negative test with overnight dexamethasone suppression test?
Previous state, like steroid, previous, like if they have taken some steroids.
Okay, so if they've taken steroids, I mean, the test itself is checking that, right? You're giving
Yes, sir.
steroids and
Yes.
checking the integrity of the HPA axis,
Yes, sir.
right? So,
Yes.
what would cause a false positive dex suppression test?
So,
See, this is very common,
yes,
and
sir.
you sometimes you ask the patient to take the dexamethasone at 11 p.m.
Yes, sir.
and they may actually forget to take it.
Okay, sir.
Okay, or
Yes.
there may be medications that can affect the metabolism of the dexamethasone.
Okay, sir.
Okay, so if the dexamethasone is fastly metabolized by, say, any cytochrome enzyme inducers,
Yes, sir.
then the dexamethasone did not have enough action to suppress the HPA axis. So that there you may get a false positive test.
Okay.
Yeah, same thing can happen with anything that inhibits the CYP enzymes.
Sir.
Okay.
Okay, sir.
All right. So in both in the urinary free cortisol as well as in the salivary cortisol, you're actually measuring the free cortisol. The name itself says free cortisol. That is unbound cortisol, just
Yes.
like your free T4 or your, like a free T3. So this is unbound free cortisol you're measuring. Whereas in the 1 milligram dex suppression test, you're actually measuring the total cortisol.
Yes, sir.
So any condition that can increase the total cortisol because they increase the cortisol binding globulin. Just imagine thyroid and you can answer, any condition that increases your binding globulin. Let's just say total T4 is high.
Yes, sir.
Where do you get it?
Hypothyroidism.
No, I'm talking about falsely high because the binding globulin is higher. Like, say, in a female patient.
No, sorry.
So it's a patient is taking a birth control tablet which contains estrogen.
Yes, sir. Yes.
Or the woman is pregnant when the estrogen levels are high. So estrogen is a common
Yes.
increase of binding globulin. So that can happen with the cortisol binding globulin also.
Okay, sir.
Okay, in those situations, you might have to do a recept as a different test and not the dex suppression test.
Okay, sir.
Okay.
Yes.
Okay, in this.
Is it Dr. Tyagarajan, sorry, Dr. Sindhil is joined? Is he joined or it appears as a Zoom user is a new person? I don't know. Is that is it Dr. Sindhil? I just thought of involving him also in the discussion. I think it's not that doesn't matter. Okay, please go, Dr. Tyagarajan. Sorry, I thought new person has joined. I thought Sindhil, but Sindhil is not there. Please
Yes,
go ahead.
I'm not sure. Okay. So, so this you see this patient, you had a MRI scan done, right?
Yes, sir.
Okay, so if the MRI has not shown anything, or if it shows, like, say, a 4 millimeter microadenoma,
Yes, sir.
then what would you do?
Sir, we can go for medical management.
No, the question I'm asking is, this is the this patient
Yes,
that
sir.
we say that's an ACTH dependent Cushing's,
Yes, sir.
right? And then you did the MRI and you're seeing a larger lesion.
Yes, sir.
But if it was a smaller lesion, like say a sub centimeter, like a sub 0.5 centimeter, can you
Okay.
confirm this diagnosis? Is what I'm saying. Is it now at the point where you can call it a Cushing's disease?
Sir, we can do the inferior petrosal sinus sampling.
Sure, I think these again. This is the situation where still
Yes,
again the ectopic ACTH secretion should be considered,
yes, sir.
because if it's a tiny pituitary lesion that you see, that may not be actually a corticotroph adenoma that's causing the Cushing's disease. So in the situation, still the
Okay.
possibility of an ectopic ACTH is should be considered. And
Okay,
you're
sir.
right, inferior petrosal sinus sampling should be done.
Yes, sir.
Again, the chances of that any centers doing that are very limited,
Yes,
so
sir.
it's very difficult to get such a test done.
Okay, sir.
Okay, so when you saw this MRI lesion, what
Yes,
did
sir.
you do next?
So patient was underwent transperineural resection of the muscle. Sir?
Okay, all right. So this patient, does have overt Cushing syndrome.
Yes, sir.
Does this patient, did you do any medical management before the patient went for surgery?
The no, sir.
Okay, so what are the goals of treatment for this patient? Like, for this Cushing syndrome, any Cushing syndrome for that matter, what are the goals of your treatment? Why do you need to treat Cushing syndrome? It's not a malignancy, right?
Yes, sir.
So why do you need to treat this disease? In this particular case, you mentioned about cavernous sinus invasion and all that. But
Yes, sir.
what if it was a small adenoma, microadenoma? Why do you need to treat this patient?
Um,
You understand the question, Dr. Shweta?
yes, sir.
Okay, so like say for example, incidentally, a small adenoma was noticed on the MRI scan
Yes,
in the
sir.
pituitary, and
Yes,
the workup is all negative, no hormonal problems.
yes, sir.
Most of the time, we don't treat it, right?
Yes, sir.
Unless it has any mass effect. So,
Yes.
if that is the case, why do you need to treat a Cushing syndrome or a Cushing's disease?
It may lead to some metabolic and cardiovascular complications.
Sure.
Yes,
Okay, so
sir.
you're right. That's what in the answer I'm expecting. And the patient already has diabetes and hypertension,
Yes, sir.
and which can worsen and has more cardiovascular disease. And overall, the risk of infections are higher,
Okay, yes, sir.
and their mortality and is higher.
Yes, sir.
Right. So like in the same in the same league, just you can answer. What should we do before we send the patient for surgery?
Sir, we should normalize the cortisol level.
Okay, but just treating the comorbidities,
Yes, sir.
the diabetes and hypertension.
Yes, sir.
Okay,
Okay, sir.
they have a higher risk of pulmonary embolism and DVTs.
Yes, sir.
They have higher risk of infections.
Yes, sir.
Okay, and especially in somebody with ectopic adrenal or with like say adrenocortical cancer.
Okay, sir.
Okay, what
Yes,
else
sir.
can be done to medically treat their Cushing's?
Sir, medical and radiation therapy also.
Yes, so radiation comes later, but what kind of medical therapy can be done?
Uh, in enzyme inhibitors,
Okay,
methyrophone like 11 beta hydroxylase inhibitors,
okay.
and
So even some common medications like ketoconazole
yes, sir.
can be given.
Yes, sir.
In severe cases, you can admit the patient to ICU and give ketoconazole to
Yes.
reduce the cortisol levels or the steroid levels before you send the patient for surgery.
Okay, sir.
Okay, sometimes
Yes.
these medications, the steroid synthesis inhibitors such as mitotane, are
Yes, sir.
very hard to get
Yes, sir.
and are very expensive also.
Okay, sir.
Whereas medicines like ketoconazole are easily available and can be given.
Yes.
Okay. And
Okay, sir.
another common medication that is there is
Yes.
called mifepristone. Have you heard about it?
Yes, sir.
What kind of medication is that?
Uh, Glucocorticoid antagonist receptor
Okay. Where else is it used commonly? Mifepristone.
in medical termination of pregnancy.
Exactly. Yeah. So those is gaining more popularity nowadays in terms of using it for sometimes even for mild Cushing's or subclinical Cushing's also.
Okay, sir.
This is just for you to know,
Okay, sir.
and this might be more in the future. But again, these clinics are easily available and not very expensive and can be used before you
Okay.
send the patient for surgery. Because in a patient with a very high cortisol levels or very overt Cushing's,
Yes, sir.
before if you send them to surgery, then the surgical risk itself is higher, right?
Yes, sir.
Okay, all right. So what other treatments are there?
Sir,
So you talked about surgery, and you did mention about radiation, right?
yes, sir. Radiation is after surgery. If, in case of recurrence or residual disease, we can go for radiation.
Okay. All right. In this case, or just for any case for that matter, how do you establish that the patient has you have cured the disease or you have a remission of the disease?
Sir, follow up MRI and the cortisol levels, sir.
Okay. So that is the most important thing. Okay. So the
Yes,
follow
sir.
up of the cortisol levels.
Yes.
Okay. In this patient, if you have followed this patient, this is Dr. Senthil Kumar sir's patient.
Yes, sir.
So these patients usually they get started on steroids
Yes, sir.
right before surgery
Yes, sir.
because we don't want them to go into steroid withdrawal after the surgery.
Yes, sir.
And then post surgery, you follow the levels to make sure that
Yes, sir.
you stop the medication and follow the levels to see the cortisol levels have come down.
Yes, sir.
What did you have any other pituitary hormones checked in this patient?
Sir, no, sir. They have checked only for thyroid levels.
Okay.
We can check for prolactin. There will be hyperprolactinemia.
Okay.
And can check for growth hormone excess.
Okay.
And hypogonadism.
Okay. So this is a postmenopausal woman. So
Yes, sir.
in this particular case may not be necessary,
Yes,
but very rarely you might have co-secretors.
yes, sir.
Okay, so usually
Yes,
corticotropic adenomas are doesn't usually co-secrete, but it's a rare possibility
yes, sir.
that acromegaly and Cushing's can happen in the same patient also.
Yes,
Okay, so that's why it's important to
yes.
measure the other pituitary hormones as well before surgery.
Okay, sir.
And after surgery, you might, when you're considering medical treatment, you can select the appropriate treatment.
Yes, sir.
I think, Dr. Shweta, one
Yes, sir.
basic practical question to you. You said that we are dealing with the problem of it's a pituitary macroadenoma. Dr. Tyagarajan was discussing extensively on the management, investigations, and medications and other non-medical therapy for your pituitary adenoma. My
Okay, sir.
basic question is, what is the field of vision in this patient, doctor? A person is having optic chiasmal disease
Yes, sir.
or having pituitary macroadenoma. What
Yes,
type
sir.
of field defect you can get?
Sir, bitemporal hemianopia.
Bitemporal hemianopia. Did this patient have? Or did you ask for ophthalmologist to see the patient?
Yes, sir. They have seen, sir. They have done.
Then what?
Sir, perimetry, sir.
Perimetry. What was the finding?
There is a thinning in the temporal quadrants, sir.
Okay. Okay. And Dr. Tyagarajan, anything else you want to add, Dr. Tyagarajan?
I think we are good through, sir.
Good through. Okay. Okay. I think if it's okay, can we conclude this, Dr. Tyagarajan? Because
Sure,
she
sir.
has done. Yeah. Really, thank you, Dr. Tyagarajan, for joining and teaching us about the endocrinological problem of Cushing's, differentiating different types of reasons for this Cushing's, like adrenal versus ectopic versus pituitary origin, and the basics about the investigation, the plan of management for Cushing's suspected patient, the relevance of basic pathophysiology behind or the reason behind the requesting for these investigations and clinical symptoms also. We also discussed about the different aspects of generalized edema patients also. Really thank you, Dr. Tyagarajan, for joining. And I appreciate Dr. Shweta for the presentation. I try to improve on your way of expression, your points, doctor. You have to go a lot to improve your quality of expressing your points. A lot of hiccups in your presentation, including your answering capacity. So it may be considered as one of the platform for you to get train yourself and remove all your inhibitions so that you just get confidence of presenting, answering your capacity much better than the current value or current situation than the exam point of view. Okay, that should be fine. Yeah, thank you, Dr. Tyagarajan, and thank you, Dr. Shweta, and thank you and good night to all of you. Thank you.
Thanks. Good night.
Thank you, sir. Good night.